Hello, Dr. Childress here. We're in my Vitae Series. Welcome. So, we're wrapping up my time at Children's Hospital of Orange County, UCI project, doing the juvenile fire setting project. But before leaving the CHALK UCI collaboration, I want to talk about one other area of my background and one of the things I did. So, my specialty, ADHD, early childhood, and I have this project I'm working on, identification of ADHD in preschoolers. And one of the criteria, diagnostic criteria for ADHD is functional impairment. So the child, so not only are these symptoms present, but there's impairment to the child's functioning. And for preschoolers, the functional impairment is one of the domains is in preschool. They're not able to sit and regulate themselves in preschool. Well, I thought to myself, what if we train the teachers in how to respond to the kids in a way that ameliorates and addresses the kids' neurological issues surrounding the ADHD. It has to do with attachment and relationship systems, intersubjectivity. It's the intersubjectivity system that is the one that's most involved in the ADHD symptoms. So if we could train the teachers on how to respond properly, we could fix this. Now, the standard treatment for ADHD is called applied behavioral analysis. It's stimulus, behavior, consequence. It's your classic learning theory package, applied behavioral analysis. That's the standard behavioral therapy for ADHD kinds of stuff. It stabilizes kids but doesn't get rid of the kids' symptoms. And so all the research indicates medication treats the symptoms, behavior therapy not so much. And so there's problems with that. In addition, as I began to develop a preschool training program, and I went to Tim Swanson and said, hey, can I do this on the side? Just train teachers all over the place. And one of his therapists over there at the school, Steve Simpson, and I worked together. And Steve was very hot on the project, too, of doing teacher trainings. And Steve was coming from the classical ABA model, the Applied Behavioral Analysis model. And we went and talked with the head of the Head Start program in Orange County. Jim Swanson arranged that meeting for us with the grand kahuna of the Head Start program. And we went and talked in organizational development. What are the needs of the Head Start program in the preschools and teacher training? And so she told us all about staff turnovers and a lot of difficulties, and indicated that the ABA model, the Applied Behavioral Analysis model, is not going to fly in preschools. No, we don't use timeout. We don't use consequences. No. What they use is called functional behavioral analysis, FBA, and that's the school uses. It's, again, a defined behavioral intervention, functional behavioral analysis. What we do is we look for what the function the behavior serves. We create an alternative behavior that serves the same function, and so we replace the behavior with the alternative behavior, and then we do various techniques to get rid of the alternative behavior. But it's identifying what function the behavior serves and then addressing that. So let's say that the kid is acting out every day at class and getting sent to the teacher's office. We come in, do a functional behavioral analysis, and identify that the reason the child's acting out is because they don't like math. And so every time the math subject comes up, they act out, get sent to the principal's office, and avoids it. And so then we have to come up with a different method to avoid math. And so one possibility is the kid raises their hand and says, can I go to the principal's office? Teacher says, okay. We've gotten rid of the behavior problem. The kid has a new behavior that's more efficient in acquiring the goal of getting out of math. Yay! Okay, so now the behavior is gone. The behavior problem's disappeared. Now we have a new problem. How to change the child saying, I want to get out of math class, to keeping them in class longer, keeping them more involved with math. And so that becomes the treatment goal of the behavior therapy, is how we start increasing the child's periods of staying in math, we add reinforcement consequences to it, and we create the behavior of participating in math. But the first step is we get rid of the behavior problem that's being used to escape, and we give them a more efficient way to do that. Functional behavioral analysis. It's required by the Individuals with Disabilities Act. It is standard of practice in the school systems, functional behavioral analysis. Okay, so preschoolers use FBA. We in ADHD use ABA. So we're just going to have to switch over. So I'd be became knowledgeable about functional behavioral analysis, and that's the trainings we presented. I would weave in my early childhood stuff kind of on the sly here, and then this is what we do. But the basic model was functional behavioral analysis. We trained, we had a 3-day training with all the Head Start people in Orange County, and that we would go in and do consulting work in classrooms with the kids' behavior problems and stuff. And that was all of my own design. It was not part of the project. I just got approval for it and started to do it. So then when I was recruited out to Cal State San Bernardino, that was one of the components that I was recruited out to do. Cal State San Bernardino wanted to develop an early childhood program. And they had professors who had experience, who had the knowledge base in early childhood mental health. But they were not clinical psychologists. They were not treatment people. They were professors. And what they were looking for was a clinical psychologist who could treat early childhood issues and supervise the staff who would be treated. And so they identified me, and I became a consultant to them first on developing their parent training and their teacher training program. And then they hired me to be the clinical director for their early childhood and assessment treatment center. Now, that assessment treatment center they developed was a big county project they were working on. They had all these couple county agencies involved. They had a consultant from Chicago to come back in and do their training in the model that they had going. We had university collaboration with Loma Linda, who provided occupational therapy expertise, and University of Redlands, who provided speech and language. And Cal State San Bernardino provided the psych and clinical psych component, me. And so there was a 3-part: clinical psychology, occupational therapy, speech and language, which is the 3 component parts that you want for the highest caliber of assessment and treatment with early childhood stuff, because language is coming on, sensory motor is coming on, and all the neurological processes. The county involvement was that we were working primarily with kids in the DCS system, Department of Children's Services, in the foster care system. So we're working with children 0 to 5 in the foster care system. Wow. Okay. So we're spot on the attachment pathology, the attachment trauma in foster care placement. Plus we have the contributing factors of prenatal exposure to drugs and alcohol, so we're over into the neurocognitive deficits and autism spectrum kind of things. In the autism spectrum is prenatal exposure to drugs and alcohol kind of stuff, and so we have those kind of components. Kids with, in the foster care system, attention deficits and hyperactivity and impulsivity are one of the symptoms to develop. They will meet criteria for ADHD. That's one of the things. And we're bringing in Perry and his whole work on trauma and the locking in of the trauma into the body kind of stuff. And so Perry comes involved. Vanderkook and developmental trauma becomes involved. And so we have this research project, or not a clinical project, collaborative project, major universities, county involvement, foster care system, attachment trauma, and the goal of the highest caliber of professional expertise possible. So I was responsible for developing the assessment protocols for these kids. And so we have the intake protocol, and that's also up on my website. You can go look at it. Structured intake protocol about the information we get in the first intake process. Then I had a staff of professional staff who were licensed, and then we had MFT interns and some postdoctoral fellows as trainees within the program. So I was doing some supervision with them. The professional staff was doing some supervision. And I would provide these training seminars for the staff. Now, in addition to all of that, I brought in the teacher training component as an intervention model for these kids. So I have kids in the foster care system. They're having problems in the preschool classroom. So one of the intervention issues is to help the preschools manage their behavior. And so here's the solution I came up with that. Similar to what we were doing in Orange County. We offered parenting skills group to all the parents, just generally, countywide. Parenting skills for preschoolers. And so we would go around and offer these skills. And then we would have a child care component to that. that we would provide. And so the parents would be into getting the parent training, and we had a group of child care people. Now, the child care people we would hire, or we would recruit, they were unpaid volunteers, recruit out of the Cal State San Bernardino psychology program. These undergrads would come out and volunteer and provide child care services. In return, they got a series of seminars from us about child development and issues, and I would run a couple of seminars in clinical pathology and early childhood, and then the other professor would do a lot of child development curriculum. And so the students would get a seminar they could put on their resume and the experience working in the child care groups, and then we would get the child care expertise. Now, the best of those child care workers, we would then recruit them to serve as therapeutic child care workers in the clinic. So we had like 5 child care workers that when the children would come to the clinic for their therapy, we would assign my model, we would assign 2 therapists, one for the parent or foster parent and one for the kid. So the kid would go deal with their individual therapist, and the parent or foster parent would go deal with their therapist. And in some cases, though, we had siblings who were involved, and so the parent would bring all their siblings and the kid would go into therapy. But we need somebody to kind of watch the siblings. In some cases, the actual patient, the child patient, wasn't involved in the therapy that day for some reason, and so we had therapists working with the parent. We needed somebody to watch the kid. So we had a little area, the toys and little kitchen stuff, and toys, kitchen stuff, and where the kid would play, and we would have a therapeutic child care staff there. Now, in addition to providing us help with that, we would give them a higher level of seminars. So I would train them in a series of seminars about psychopathology in early childhood, and so meet both of our needs on that. Now, the best of those therapeutic child care staff, we would hire, they'd be paid, we would hire them to be one-on-one or interventionists in the preschool classroom, so in the Head Start classroom or in wherever that child is, or in the foster care home. We would send them out to the foster care. So we would insert them, we would help them where the child's having problems. And so they would get even a higher level, and they would also get supervision on a caseload of kids in the foster care system that we were getting that are specialized expertise as a scaffolding support for the child, in addition to the therapy they got in the clinic, in addition to whatever else, the occupational therapy, speech and language therapy, all the other features. So let me stop this here and move on to the next segment, where I'll talk a little bit more about what we did at the